Benatar, who's a professor of neurology at the University of Miami, and speaking on behalf of Biogen in describing the ATLAS study, the design of a phase 3 randomized placebo-controlled trial of Tofersen initiated in clinically presymptomatic SOD1 mutation carriers.
Great, thanks so much, Bob, and my thanks to the organizers for the opportunity to talk to you today about the ATLAS study. So I think this audience knows this, but I want to just sort of highlight two of what I think are critical challenges in ALS therapy development that are relevant to how we have thought about the design of the ATLAS trial. So the first is, as we know, that typically our treatments are not targeting the underlying cause of disease. And I think we know that, and for the most part, we don't know the cause, with the exception of some of the genetic forms of this disease. But the other lingering concern which we face in almost every trial that we do is the delay in initiation of therapy. I mean, that's a delay not just from onset of symptoms or diagnosis, but potentially from the point in time when disease begins, and how far in advance of clinically apparent disease the disease process begins. And so these observations are relevant, I think, to how we think about the therapeutic strategies. And so here, in this particular study, we're targeting the underlying cause of a disease when the disease is known. And in this instance, mutations in the SOD1 gene. But the idea here is to say, can we target people pre-symptomatically in those who are at genetic risk for disease? And in this particular instance, those people who are unaffected SOD1 mutation carriers. So again, this audience knows about SOD1 ALS. That accounts for about 2% of people with ALS, and that these disease-causing mutations lead to protein misfolding, a toxic gain of function, and ultimately, through mechanisms that are not entirely understood, to neurodegeneration. But let me spend a few minutes talking a little bit about this idea of presymptomatic ALS and how and why it is so challenging to think about therapeutic intervention at this stage. And so this is the conceptual model that we have, at least in the genetic forms of disease, that we think about a genetic susceptibility to disease. And then at some point, disease onset occurs, and that's currently in vivo something that we are really unable to define. And we think about disease itself as having at least two stages, a pre-symptomatic stage and a symptomatic or a clinically manifest stage, which is how we traditionally think of ALS. Within the pre-symptomatic space, I think there are probably at least two stages to disease. The one is one that is clinically silent, or what we call pre-manifest. And the other is a prodromal stage, which, depending on the nature of the disease, the genetic mutation may be characterized by mild motor impairment, mild cognitive impairment, or mild behavioral impairment. And we've used this term phenoconversion, which I'll come back to in the design of ATLAS, to indicate the transition from pre-symptomatic disease, which may include some prodromal manifestations of disease, to clinically manifest ALS, which is that clinical syndrome that we well recognize. And this model has emerged from our work through the PreFAL study, the presymptomatic familial ALS study that's been ongoing now for about 15, 16 years. And the goal of this study really were to identify biomarkers of presymptomatic disease and then to prepare for disease prevention or early intervention. And so the challenge when we're thinking about a presymptomatic intervention is when to intervene. Unlike, for example, the CAG repeat in Huntington's disease, in SOD1 disease and in genetic forms of ALS more generally, we really have little to no ability to predict the timing of onset of disease. And so somebody with the same genetic mutation may develop disease when they're 20, when they're 50, or when they're 70 or 80. And so if we want to intervene pre-symptomatically, we really need to know in whom do we intervene and when. And neurofilaments have now emerged as biomarkers of axonal degeneration that really can serve as the first biofluid marker of pre-symptomatic ALS. So this is just a snapshot of some data that's a few years old, and I'll orient you to this. But here we're looking at time to or from symptom onset. And time 0 here is phenoconversion. This sort of bluish grayish box is the maximum value of neurofilament light that we observe amongst controls. And on the y-axis, a log of serum neurofilament light. And what you can see in these shaded circles is amongst carriers of highly penetrant SOD1 mutations that are associated with rapidly progressive disease, we see an elevation in serum or plasma neurofilament light levels within the 6 to 12 months prior to phenoconversion. Just parenthetically, we see that neurofilament levels continue to rise shortly after phenoconversion, but the notion is that this presymptomatic rise in neurofilament is what might enable us to flag those people in whom we could and should initiate therapy presymptomatically. So we've used this data to develop a neurofilament trajectory model to inform the design of ATLAS. And this again is using data from carriers of highly penetrant SOD1 mutations that are associated with rapidly progressive disease. And this is using the Siemens Health and Years assay, and I think the specific assay matters in terms of where we set the threshold. But using an absolute threshold of 44 picograms per milliliter, with an additional criterion of an increment in neurofilament light of at least 10 picograms per millia from a baseline assessment. And we had to introduce that second criterion given the effect of age on neurofilament levels. If we look at the predictive value of these thresholds for predicting phenoconversion to clinically manifest ALS within the ensuing 12 months, this threshold, this approach, gives us a very low false positive rate and also a very low false negative rate. So only 1 of 12 people within 12 months went on to develop disease without us having observed a rise in neurofilament levels. And so we've used this information then in the design of ATLAS. So the goals of ATLAS are to evaluate the impact of initiating Tofersen, an SOD1 antisense oligo, based on biomarker, in this case, NFL evidence of disease activity, and doing this prior to the emergence of clinical symptoms or signs that definitely indicate ALS, so prior to phenoconversion. And as I think this audience knows, Tofersen is an ASO that Biogen is developing for the treatment of SOD1 ALS, and I'll move past this quickly because I think this is well known. So what then are the goals of the ATLAS study? It's to evaluate whether presymptomatic initiation of Tofersen can delay the emergence of clinically manifest ALS and or slow the decline in function after clinically manifest disease develops. So the idea here, one, is can we delay phenoconversion? But even if we can't, are we slowing the course of disease, and is there less functional decline or a slower rate of functional decline after clinically manifest disease develops? And the primary efficacy endpoint here is the proportion of participants in whom clinically manifest ALS develops within 12 months of randomization. And I'm going to show you on the next slide when randomization occurs so that you can fully understand how we think about that primary efficacy endpoint. So here's a schematic of the ALS study, of the ATLAS study design, and there are 4 parts to this study. So part A is a natural history running study. So after people have been screened and enrolled, they are followed without a study treatment for monthly, and they're followed with monthly neurofilament light levels. So these are people who are pre-symptomatic. They carry an SOD1 mutation that we know is highly penetrant and associated with rapidly progressive disease. They have a low neurofilament level at initial screening, and then we're following neurofilament every month. And we plan to enroll about 150 people in this category. People will then proceed to part B if we detect an elevation in neurofilament light above that threshold that we described, that 44 picograms per milliliter, and also a 10 picogram per milliliter increment from baseline, and they remain clinically pre-symptomatic. And they will be randomized 1-to-1 to receive placebo or Tofersen. And we anticipate enrolling about 28 people in part D. And they will be followed to their primary endpoint of phenoconversion, or the onset of clinical signs or symptoms that clearly indicate clinically manifest ALS. And at that point, if eligible, they will proceed to screening for part C, which would then take them into an open label extension phase where they would be on Tofersen 100 milligrams. We do anticipate that some people may go on to develop clinically manifest disease in whom we did not detect a neurofilament light elevation. And if that happens, then people will go directly into Part D, which is an open label phase as well, where they'll be on active drug. And we anticipate that Parts B and C and Part D will extend up to about 2 years in duration. So here's whom we imagine will be the study population. These are just some of the key eligibility criteria. So at least 18 years of age at the time of informed consent, a carrier of either a protocol-defined SOD1 mutation, and we've listed these here, or an SOD1 mutation that has been adjudicated for inclusion by an independent mutation adjudication committee. The idea being here that we have incomplete knowledge of the landscape of SOD1 mutations and what the penetrance and the clinical manifestation of the course of that disease might be. And so we have an independent group who will look at a mutation that might come before them to decide whether that person is eligible. But the criteria are whether this looks to be highly or completely penetrant, and whether it's expected to be associated with rapid disease progression. Obviously, their plasma neurofilament level needs to be below threshold at the time of screening, and they need to be clinically presymptomatic, i.e. they must not have clinically manifest ALS. So again, as this group knows, I think Tofersen has been evaluated in the phase 3 VALOR study, and I'm not going to try to recapitulate all of those results, but remember this was in an affected population. So adults with SOD1 ALS who do have an SOD1 mutation, they were randomized 2-to-1 to 100 milligrams of Tofersen or placebo. And then after 6 months at the primary efficacy readout, everybody had the option to go on to the open label extension. And that's relevant to some analyses, which I think not inform because ATLAS was designed before this readout came, but support the design and the approach to ATLAS. So as you know from the recent publication, VALOR did not achieve statistical significance on its primary endpoint of a change in ALS-FRSR at 6 months. However, there were some consistent effects observed across key secondary and exploratory outcome measures. And I think the key to highlight here are the reductions in CSF SOD1 protein as a marker of target engagement, and also the reduction in plasma NFL, suggesting a slowing or a reduction in the rate of neuronal degeneration. And there were some adverse events, and I'll come and talk about these in more detail in a moment. And this becomes especially relevant to thinking about treating pre-symptomatic people and the duration of that pre-symptomatic treatment, and why it's so important that we know when disease or clinical disease might be coming, so that we're intervening at the appropriate point in the natural history of disease. So these data from VALOR were then integrated across the double-blind and the open-label extension studies to look at the impact of early versus delayed start of Tofersen. The idea being here during the double-blind phase, there was a group that was on Tofersen and a group on placebo, but in open-label extension, everybody's on active drug. And so the group that started active drug during double blind is the early start, and the group that started only during the open label is the delayed start. And then the analysis I'm going to show you is based on the most recent data that have been presented, where all participants had the opportunity for at least 1 year follow-up. And I should say in this analysis, baseline plasma NFL was incorporated as a covariate, as a prognostic biomarker, in order to more precisely control for the heterogeneity of disease progression. And this approach to using baseline NFL in this way was done post hoc. So here are some of the integrated data analyses. And what I want to draw to your attention, here's the CSF SOD1 levels. And you can see the early start and the delayed start. You can see the reductions in SOD1. Again, you can see the reductions in NFL. But importantly, I think if you look at some of the clinical metrics and look at the ALS-FRSR, obviously a lower score is worse. And here we have the delayed start, and here we have the early start. And we're beginning to see that there may be an effect of starting early, with a similar effect seen in SVC. And I'd remind you, my recollection at least off of the subgroup in VALOR with rapidly progressive disease, that the median duration of symptomatic disease was about 8 months. And so in ATLAS, we're trying to initiate treatment even before clinical symptoms begin. So trying to get really early in the course of that disease. So here's a quick summary then of the adverse events in VALOR, and these have been published, but I want to draw your attention to some of the neurologic serious adverse events, including myelitis, chemical or aseptic meningitis, lumbar radiculopathy, increased intracranial pressure, and papilledema, occurring in about 7% of the population. There was also not insignificant frequency of adverse events in the form of an elevation in CSF protein and a CSF white cell count. But the relationship between these biochemical changes and the adverse events, I think, is not entirely clear. But again, I think relevant to the idea of the risk-benefit ratio of treating early versus late. And I think that's still a question that we hope to answer through the ATLAS study. So to summarize then, I think that ATLAS is designed to further our understanding of the optimal timing of Tofersen initiation. Is it enough to intervene at some point after diagnosis? ATLAS will tell us, at least in a double-blind fashion, whether initiation pre-symptomatic is key or whether it may be sufficient to initiate at the time of phenoconversion. And I think then integrating those data with the VALOR data of initiating therapy later will be very informative. But ATLAS will also further our understanding of pre-symptomatic and early clinical disease. This is being conducted globally across 30 sites, and screening was initiated in the second quarter of 2021. I've told you about the data from VALOR that showed the target engagement and biological effect, and suggesting that earlier treatment may have an impact on clinical function. And then lastly, my thank yous and acknowledgements to the participants in the Presymptomatic study and my team at the University of Miami, who were able to help us generate the data to help move this study forward, as well as the ALS community and to the sites participating in the ATLAS study. And so, Bob, I'll stop there, and I think I'm a little ahead of time and have time for questions.
Thank you so much. It has to be said, Michael, that this is an immensely important project, and it clearly is where the whole field wants to go, which is to say, to recognize the earliest manifestations of and treatment for these diseases. So kudos to you. That's fantastic. We have some questions in the chat, and I have a couple of questions, but Lane Olaf has asked, do you think the FDA submission for Tofersen will have an impact on recruitment? Will approval slow recruitment?
That's an interesting question. So I'm going to talk, again, I have to talk from my perspective. I don't know Biogen's official position on this. So I'm talking as Michael Benatar at the University of Miami. I mean, I think that application for accelerated approval is focused on treating symptomatic people. I think we do not know the risk-benefit ratio of treating people pre-symptomatically. I certainly would be cautious about taking a pre-symptomatic individual with a normal neurofilament level and treating them with Tofersen. You could be treating somebody for 30, 40, 50 years before they were to develop disease, and we don't know what the safety profile of that looks like. You know, will it impact recruitment? I don't know. Maybe it'll accelerate recruitment. I hope so. In that, you know, if this were to be approved, that people would say we need to move forward our ability to understand the importance of the timing of treatment. So it's a great question. I don't know. I'm throwing out just some thoughts.
Thank you. Thank you. Stacy Rudnicki has asked, can you elaborate on how the study is powered?
Thanks, Stacey. So I'm not the biostatistician, so I probably won't do this justice, but let me have a go at this. I think this is sort of based on some Bayesian thinking about the probability of phenoconversion within the designated time period and within a 12-month period based on an elevation in neurofilament, and how that probability changes and favors active treatment or not as events occur in the placebo-treated group or in the active-treated group. And so I'm hoping there may be a statistician or a Bayesian statistician in the audience who can explain that further. But the idea really is sort of the shifting probability of whether these phenoconversion events are occurring by chance, and what the distribution of that looks like across the placebo and actively treated groups.
Thank you. Michelle Lorenz has asked, now that NFL assays are readily obtained, even commercially, do you recommend that people track their NFL levels with their personal neurologists?
So I think this is shark territory is my own view of this. So I'm delighted to see the neurofilament is in clinical practice, and I think there's an enormous amount that we need to learn. I would remind everybody that neurofilament is entirely non-specific. There are many, many things that will push your neurofilament level up. A hit on the head, a peripheral nerve injury, a diabetic neuropathy, an acute radiculopathy. I think it's going to require lots of clinical judgment to figure out how to interpret a neurofilament level. And so I think if you're going to do this, you want to be having close discussions with your thoughtful neurologist to figure out what to make of this. So I would be super careful. Buyer beware.
Thank you. Thank you. So I wanted to ask you just a couple of quick questions vis-a-vis the biomarkers. So you used, is this correct, plasma NFL levels?
In pre-FELS or in Atlas?
In pre-FELS. Well, let me ask you.
Yeah, so we've looked at both serum and plasma. They correlate well with each other.
Yeah.
And we've generated data across a range of different neurofilament assays. And, the blood-based data performs very well.
Yeah. In other words, because that was going to be the question, is there any merit, although it's difficult, in looking at CSF as compared to peripheral analysis of the levels?
Yeah, I mean, the truth is, even in pre-FELS, we don't have the same density of sampling data to adequately capture the timing of this. And the value of the blood, and I think that's, in a sense, the real power of neurofilament, is that we can measure it in serum or plasma, and that we can do this in people's homes every month, which would just be impossible with CSF. And I worry that the window of opportunity to intervene here is relatively short. And this is part of that trajectory model, Bob, was we needed a threshold above which there would be, a relatively low false positive rate, but we also needed time to get the result back, screen people, make sure there was no other explanation, and then intervene and begin to dose before disease would become clinically apparent. So I think the practicality is that we just couldn't do this using CSF. And so that, in a sense, is the real utility and power of neurofilament.
I think you're right. I didn't see in your data, and you might have mentioned, I don't recall, were there any false positives?
There were, in this analysis, no false positives. There was one false negative.
Okay, thank you. And the last question comes from Giampaolo Merlini. The reduction of SOD1 with Tofersen was only 33%. Of course, we don't know the corresponding brain reduction, but should we aim for higher reduction?
The honest answer is, I think we don't know. But Bob, maybe you can comment on that. From my perspective, I think we don't know.
Yeah. I mean, my only thought is that we don't yet know what the parenchymal reduction is, and it may actually be well beyond 33%.
Right.
So I think that's a possibility. Well, look,
I think if I could, Bob, sorry, just to reflect that, I think the 60-ish% reduction in NFL is obviously super encouraging. I guess we'd love to see it come down to normal, but a 60% reduction is sort of a very meaningful reduction, I think, given what we see in sort of untreated natural history studies.
Yeah, absolutely. Well, again, Michael, thank you for this really powerful and important work. So I think at this point, we're set to take a break.